The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this month to be talking to Dr. Mitch Strominger from Nevada about conjunctivitis. So you're in Reno, is that right?
Beautiful Reno, Nevada.
It is a beautiful place.
Snow the other day, and some of the ski areas have just opened up.
Oh, nice. It's almost December and the Utah resorts haven't opened yet.
We're at high altitude, so they can blow snow up there.
Yeah. And you're a neuro-ophthalmologist, is that right?
So I did my ophthalmology training, and then I did actually 2 fellowships. I did a fellowship in neuro-ophthalmology, which is a year, and then I did a fellowship in pediatric ophthalmology, which is another year.
So you're a very well-trained guy.
Some would say too much. Actually, before ophthalmology, I did internal medicine first, so I don't know what happened. You know, I tell people when I was in med school and was doing ophthalmology residency, I hated working with kids. And now look what happened.
And now look what
Pediatric ophthalmologist. And I work with kids all day long.
They pulled you in. They got
You know what? It keeps me feeling young.
Sure.
Well, the only thing I have to keep up with all these new cartoons and stuff. So I turn that on, to check out what's the latest. My wife thinks I'm nuts.
Sure. You got to know who Bluey is just as a start.
Right. Yeah.
Yeah. Have you developed any disclosures since we talked last week?
No, I have not developed any disclosures.
Okay. Well, we're soliciting for you. So we'll
all right.
we'll
Thank you. I appreciate it.
Let's talk about bacterial conjunctivitis. Now, I believe from looking at your notes that it's the most common of all the conjunctivitis or conjunctivitis or something.
Yeah. You know what? It's shocking because I always ask this question at the meetings when I talk to pediatricians, what's the most common cause of conjunctivitis? Because if you're going to treat a patient who comes into the office, or more so, if you're going to call in a prescription for something, right? And not even see the patient, you want to know what's the most common cause. And it turns out that it actually is bacterial conjunctivitis. There's a couple old studies. I don't know if you could do these anymore, but I think these pediatric ophthalmologists sent their residents into pediatricians' offices, and then they cultured actually every conjunctivitis that came in or made the diagnosis.
Wow.
And they found that bacterial conjunctivitis was the most common at around 80% or so. And then it's viral and then allergic, because we always think that viral's going to be the most common. So
right.
We've had debates as to why this occurs, but I think probably, in my personal opinion, is that, anyone who has a viral illness, a viral conjunctivitis, especially a toddler or kid, what are they going to do? They're going to take those filthy hands and rub their eyes. And then I think a lot of them are getting secondarily infected too. So they didn't really distinguish secondary infection with the bacteria versus primary, but that may be why it's a little higher.
And as you mentioned last week, the greatest number of viral cases of conjunctivitis are adenovirus. And so if you get it secondarily, there are a whole bunch of other respiratory viruses you can get.
Right. Yeah. But then what happens if you could secondarily infect yourself by just rubbing your eyes or who knows what, right?
Sure. So how does bacterial conjunctivitis look? And in a nutshell, does it look different from viral conjunctivitis?
So when you see viral conjunctivitis, it's more of that kind of pearly looking, clearish type of discharge and maybe some preauricular adenopathy and pharyngitis, whereas bacterial conjunctivitis is associated with otitis and sinusitis. And then you get a sort of this purulent yellow-green discharge. So usually it's pretty easy to tell a bacterial conjunctivitis because these kids come in and their eyes are just goop, right? Sometimes by the time I see them, they've already been treated with antibiotics or being treated with antibiotics for otitis or sinusitis. So I always ask that question, do they have a sinus infection? Have they seen their pediatrician for the sinus infection? Do they have frequent ear infections, that sort of thing? And so that's how they sort of look a little bit different.
Now, we hear the story all the time. The child woke up this morning, eyes were glued shut.
Yeah.
But as the day goes on, there's really not much of a discharge. What does that mean?
Well, what happens is that during the day we blink, right? And so we blink, and every blink sort of washes the tear film, which includes that mucousy component to it, and then the aqueous and the oily component, and that basically washes the eye. If you're blinking during the day, all that bacteria and stuff is going down into the nasolacrimal system, into the nose. And what happens is at night, you're not blinking. So a lot of times it's just accumulating there in the morning. If I hear that a baby has a conjunctivitis because they have this kind of mucopurulent discharge along the eyelashes in the morning, I'm actually thinking that's more of a nasolacrimal duct obstruction. If it's an older kid, obviously that's not the case. But when I see someone within the first year of life, that's the more likely cause. And the eye itself is usually white. So other than that matting, goopy material that's on the eyelashes, especially in the morning, the parents wake up, the eye does not look otherwise inflamed. Whereas in bacterial conjunctivitis, conjunctivitis means the conjunctiva is inflamed, it's red, and it can be fairly segmental or diffusely red, depending. So that's sort of how I distinguish it.
Is the pattern of swelling any different between the two?
You mean bacterial and viral?
Mm-hmm.
Not really. The eye's just inflamed. So sometimes you can have, depending upon the virus, you might have more eyelid swelling, but in a really bad bacterial conjunctivitis, you can have that as well.
Okay. Is there a structural reason why it's associated with otitis and sinusitis, or is that the pathogen related?
Yeah, I think it's the pathogen. If you look at it, the pathogens in bacterial conjunctivitis are almost all the same as otitis. If you look at the studies, the number of ones probably H flu, and then you have strep, and then you have staph, and then you just have Neisseria catarrhalis. So those similar organisms that are causing otitis and sinusitis are causing bacterial conjunctivitis. Yeah.
How contagious is it compared to viral conjunctivitis?
Well, we think about viral conjunctivitis as being more contagious, but that's not necessarily the case. Actually, bacterial conjunctivitis can be fairly contagious, especially, how close contact you have with the kid, especially if you're a parent or a sibling. And so there are cases out there of fairly contagious bacterial conjunctivitis going around communities. And so that's why sometimes it's difficult to distinguish between viral conjunctivitis, because you think about that as being more contagious, but that's not necessarily the case. We always think about, when we treat any disease, making sure we treat it appropriately so we can rule out like a masquerade type of syndrome, right? So, and that's the same thing with bacterial conjunctivitis. Bacterial conjunctivitis should respond pretty dramatically to your topical antibiotics. And if it doesn't, then you have to start thinking that something else is going on. And we can talk about this on our next segment when we talk about allergic type of conjunctivitis. But that's probably the number one thing I see in my office, is that you have a patient being treated for bacterial conjunctivitis and they're not responding to that antibiotic. So all of a sudden the pediatrician prescribes a different antibiotic and they're not responding to that. And they may even try a third antibiotic before they finally refer in. So, you want to treat them appropriately with the appropriate antibiotic.
So tell me about that. How do you choose the right antibiotic?
Well, I can tell you my personal feeling about it. And some of it goes back to some older outbreaks when they looked at areas in the country. And the biggest thing was there was an outbreak in Maine back in, I think it was 2002 or something like that, where the CDC actually came in and there was a couple hundred cases that were being spread around the community and through a school and the teachers and everything like that. And it turned out it was a non-encapsulated strep pneumonia. And so we still see strep out there. And some of these outbreaks are the ones that the kids aren't getting the vaccine that's towards that specific strep. And of course, now if we're seeing kids not even getting vaccinated, we might see more of this. But the problem is that it was highly resistant to erythromycin. And so my sort of feeling is that if you're going to treat for bacterial conjunctivitis, you have two choices. You could use a topical antibiotic that is a bacteriostatic antibiotic, or you can use a topical antibiotic that's a bactericidal antibiotic. So if you're going to use a bacteriostatic antibiotic, you really need to use it appropriately, right? Because you're basically preventing division. So if you look at what's recommended for erythromycin, if you're going to use that, it's a 1/4 inch, 6 times a day. Well, I can tell you, there's no parent that I know of will put an antibiotic ointment in their kid 6 times a day. It's almost impossible. They can barely get it in. They can barely get it in 3 times a day.
Right.
And so you're breeding resistance in the community by using erythromycin, and it's not going after the strep because a lot of times the strep is resistant. You know, a lot of people use a polymyxin trimethoprim combination. If you look at what's recommended for that's 1 drop every 3 hours for 7 to 10 days. And again, you're never going to have a parent use that. So I tend to like using a bactericidal antibiotic because it pretty much covers staph, strep. And the other interesting thing too is it depends upon your population. If you're dealing with teenagers, you have to worry about Neisseria, right? So fluoroquinolone will cover that and also covers chlamydia. And so some of the bactericidal antibiotics have been used now for bacterial conjunctivitis, and you only need to use 1 drop 3 times a day for about a week. And there's some studies suggest you can probably get away with 1 drop 2 times a day for a week. Now you have to look at some of the other fluoroquinolones when you look at the Red Book and all these other places in terms of how to dose these antibiotics. Now, most of the antibiotics, the dosage schedule is actually based on corneal ulceration in bacterial corneal ulcers, and mainly in the adult population. So some of these drops, the recommendation is you use 1 drop every 2 hours for the first 24 hours, and then 2 to 4 times a day for about 2 to 7 days. But that's not for bacterial conjunctivitis. That's for corneal ulcer dosing. So, you know, I think you can get away with using a fluoroquinolone 3 times a day for about a week. And the other thing then is if it doesn't get better within a couple of days, you know, you have to start thinking that this is not a bacterial conjunctivitis.
Do all cases need treatment?
Well, if you actually look at it, a lot of times these do improve over time, and it depends upon what else is going on. So if the kid is already on antibiotics for otitis or sinusitis, then theoretically, you don't necessarily need a topical antibiotic. But I can tell you, it typically does make it go away quicker, right? So the question is, if you want to get the kid back to school within a day or two, you're better off treating them right away. And so that'll decrease their contagion as well. So typically I do recommend using a topical antibiotic, even if they are on an oral antibiotic for otitis.
So you would do that in addition, the oral antibiotic wouldn't tend to cover it.
I recommend that. If you think about it, ophthalmology is a funny field. Where else can you actually put an antibiotic drop on a bacteria?
Right.
You know, so if you put a bacterial drop on a bacteria, you know, that's pretty good treatment, I think. It doesn't have to go through the bloodstream. It doesn't have to be absorbed through the stomach, you know, all these things that we do for systemic antibiotics. You put that drop on that bacteria, it's not going to survive.
How long do kids need to stay home with what you're persuaded is a bacterial conjunctivitis?
I think they usually could probably go back the next day. If you're going to use a bactericidal antibiotic and they're, feeling better the next day and you've had them on for 24 hours or so, I think the risk of them being contagious is pretty low. That's another reason why maybe to start them on a topical antibiotic too. Now, have to take into consideration other things. Obviously, you don't want to send them back if they're running a fever and have sinusitis or otitis. There are other reasons maybe not to get them back to school right away.
We talked about the issue of fomites. Anything else we should be thinking about in terms of infection control?
You always have to tell the parents that they had to have picked up this bacteria somewhere, right? So you just don't want them to reinfect themselves after being treated.
How often does that happen that somebody gets reinfected?
It's rare. That's why I think that if you're treating with your appropriate antibiotic and it's not getting better, you have to start thinking that it's not a bacteria, right? So I see these kids coming in, they go to urgent care, whatever, and they're using erythromycin ointment. Obviously, they're not using it 6 times a day. And then 2 days later, they're back in the pediatrician's office. And then, okay, now we're going to use polymyxin trimethoprim. And they're still not using it 4 or 5 times a day. And then it's not getting any better. And then they come in and, oh, now we're going to use a fluoroquinolone and that sort of thing. And in the end, it's probably not bacterial conjunctivitis. So, those are the kids that I think need to be referred to the pediatric ophthalmologist. The other thing is I always tell the pediatricians, we certainly have a lot of rural kids in Nevada, and sometimes it can take hours or maybe you can't even get to the pediatrician because of a snowstorm or something like that. So that's why I say, you know what? It's not going to hurt if you call in a fluoroquinolone and have them use that. And if it's not any better within a day, you better see them, right?
Do you have a favorite fluoroquinolone, by the way?
I do. I like moxifloxacin,
Okay.
and that used to be a brand, but it's a generic now. Those are the ones that have the study where you could use it 2 times a day for a week, and it seemed to work just as well for 3 times a day for bacterial conjunctivitis. So I typically tell the parents 3 times a day, and then I'm happy that they get it in twice,
And the beautiful thing is, as you mentioned, you can put the antibiotics directly on the germs. The tough thing is you do have to put them in the eyes to get them on the germs. And that, in some
Right.
cases, that's going to be a challenge.
Yeah, but what I usually tell the parents is if they're struggling, you don't have to hold the kid down and pull the lid down. What you could do is you can lie the kid back in the bed and they can keep their eye closed and then just, you might waste a little extra antibiotic, put 1 or 2 drops in that little pocket there towards the nose and the eyelid. And then, they'll open up their eye. And if they're lying flat, the drop sort of sits there until they open the eye up and then it goes in. So sometimes I'll do that.
Great technique. You touched on the idea of orbital cellulitis last week. Anything we should be on the watch for with preseptal and orbital cellulitis in these kids?
Well, it's the same thing. If you have a really bad sinusitis and a bacterial conjunctivitis, you can get a preseptal cellulitis associated with that. And then you want to start them on an oral antibiotic if they're not an oral antibiotic. I would say it's pretty rare for me to see a preseptal cellulitis, maybe in like a Neisseria case or something like that. They can get a lot of eyelid involvement. Most of the preseptal cellulitis that I see is going to be caused by secondary infection from a sty or chalazion. So those can get secondary infected with staphylococcus, and sometimes you can get fairly severe eyelid swelling. And so in those cases, I recommend putting on oral antibiotic. But they shouldn't have those mucopurulent discharge that you would have in a bacterial conjunctivitis. So usually it's pretty easy to tell the difference.
You mentioned treatment of styes. Aside from just watching and encouragement, when should you be concerned that it's become secondarily infected or that it needs more attention?
Well, the whole eyelid gets chalazion or blockage of the meibomian gland orifices, and then you get backflow of the oily material, and you get that bump in the eyelid, and then the eyelid's a little swollen right around that area. if they get secondarily infected, the whole eyelid's going to be swollen, not just in that one particular spot. And then it can sometimes extend if it's lower into the lower orbital rim, or if it's superior up until the superior orbital rim or on the side of the face. So those are the cases that need oral antibiotics, I think.
So to recap, you talked about the appearance of a bacterial conjunctivitis and emphasized again that the appropriate use of antibiotics is the key here. The right choice of antibiotic and taking into account how it's given and the limitations of an antibiotic if it's not given correctly.
Absolutely.
Anything else we ought to be thinking about with the bacterial conjunctivitis?
I think we covered most of it.
As you mentioned before, especially something getting worse, touching base with our pediatric ophthalmologist is key.
Yeah, I think that's the biggest. The biggest thing is that, and it's with any disease, right? You want to treat the disease appropriately. And if it's not getting any better, you have to start thinking about something else going. And so if bacterial conjunctivitis isn't getting any better on appropriate antibiotics, then it could be that it's not a bacterial conjunctivitis, it's something else.
And as you mentioned, the physical exam is, along with the history, key. And one of the great advantages you have is being able to approach an exam with equipment and expertise that we don't always have.
I suppose that's the case, but I think, any pediatrician, you certainly have some sort of pen light and you have your direct ophthalmoscope, which is great because it illuminates, it has a light on it. And then if you dial it into the green, it's a magnifier. So if you want to look at anything, pull it off the wall. I've showed pediatricians how you can actually look at a splinter in a finger by using that, because most pediatricians don't necessarily have like surgical loops around or a lot of magnifiers, but that is great. You can get a lot of magnification. You have your light source right there. Bacterial conjunctivitis has that goopy discharge. If you see one coming in the office, you'll know it. It should be pretty obvious. You obviously want to make sure that their vision's good and their eyes moving around fine to make sure it's not something else like an orbital cellulitis or another type of disorder.
Excellent. Dr. Strominger, thanks for your expertise. Thanks for your time. This has been very enlightening. Please send your questions to questions@vcurb.com. We'll deal with those in a couple of weeks, and we will talk again next week. Thanks, Mitch.
Thank you. Appreciate it.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who composed the theme music. See you next time.